need instructions on how to meet in person, I think. We're going to be like, oh, do we shake hands? I don't even know. All right. So we've got our chats. I'm going to be monitoring the chat. We're going to do a quick poll. We're going to be doing PowerPoint presentations. Next slide, please. Michigan Health Information Network, MiHIN. We convene people to legally, securely, and technically ensure that data can be shared in ways that protect people's privacy, but also we're trying to elevate care. We're trying to take care of our people, and we're trying to help you take care of our people. And we are the state designated entity for the secure electronic exchange of statewide health information. Let's do this. Next step, next slide. I'd love to know, I really would love to know the makeup of the people in the room today. I need to make this so that you want to come back. I need to make it so that you are finding out what you want to know. So there's going to be a quick poll. Tell me, where are you from? So we can see the makeup. Kyle, can we do that cool web chat? There we go. Who do we have in the audience today? I'm giving you 30 seconds. Are you just a Michigan resident and interested in how MiHIN and its partners work to help improve your health? Do you work for a hospital? Do you work for an insurance company? Do you work for the state? Why are you here? Soon we're going to find out. Poll is ending. I love this. Let's see what our makeup is. Kyle, can we do it? Yes, no. No answer? I love the no answers. Oh my God, no answer. This is so okay, ready? I have a new goal for the download. People shall answer. All right, I'm going by fine. Great. We're gonna fine. We're gonna do this so that I understand things then. This is for me. And if I don't understand, I will be asking questions. MiHIN presenters. If I don't get if I'm not downloading what you're throwing out, I'm gonna like interrupt you and ask questions. And hopefully our participants will appreciate that. Let's get going. Next. No answer. This is the welcome. Hi, thank you for being with us. Next, we're going to do, oh man, social determinant of health use case, annual release announcement. This is unbelievable stuff. We are going to then learn about our care coordinator onboarding process, which fits in to social determinant of health. And then we're going to be learning from Mary Krantz. We're going to be listening to some industry trends and fire educational information. Hopefully we will have lots of questions, lots of participations from our no answers. And then we will adjourn to come back next month, bolder, smarter, and more connected. Thanks. I think we're passing it over now to Lisa Nicolau, the Social Determinant of Health Program Director, and Michael Taylor, Senior Product Marketing Manager. Take it away, folks, except I'm going to interrupt if I don't understand.
Can everybody hear me? All right, very good. So Joanne, thank you for that. As Joanne said, I am the new program director for social determinants of health. That is a position that was really created just in August of this year, and it really grew out of the need to be able to congeal the rapid pace of change that is happening within the context of social determinants of health, and across the state, across regions, and nationally. So there's a refocused effort to be able to move forward in this direction in a cohesive way. And I am joined today by Mike Taylor. Mike, do you want to flash yourself and say hi?
Sure. Hi, my name is Michael Taylor, and I am Senior Product Marketing Manager, and I work on the social determinants of health screenings use case and product.
All right, Kyle, if you want to move on to that next slide. So I'm not going to take up your time reading through this, but we've got a really packed agenda, so I'm going to try to move through this as quickly as possible. And we're going to start to bring everybody onto the same page without really understanding where everybody is at and their understanding. We kind of want to start from the ground up and build that knowledge base. Kyle, next slide. So I'm going to let Mike take it from here because Mike is far more technical than I am. So take it away, Mike.
Yeah. So a lot of times when we've given these presentations in the past, we assumed that because you were at a MiHIN stakeholder type meeting that you knew a lot of things about MiHIN to start with. So I want to give a real quick refresher about use cases at MiHIN, and there's good reason for why I bring it up, the social determinants of health. MiHIN really breaks, a lot of states try to solve health information exchange by saying, everyone send us your data, and then we'll have this big pile of data that everyone's allowed to query when they need information. But that was big and scary, and a lot of people had a lot of concerns. And the way MiHIN has approached things is we break things down into individual use cases that are explicit about what data we're sharing, and we're comfortable sharing this data for this specific purpose, and here's what participants are allowed to do with this data. And when you layer a bunch of use cases that everybody's comfortable with on top of each other, we can still accomplish big goals, but it allows us to get to that level of comfort with each particular slice of that. And really that's important for social determinants of health, because social determinants of health is a really big domain. And the bite we bit off for the social determinants of health use case is really focused on screening data. So organizations are asking surveys, asking screening questions about social needs that people may have, and the passing of that information is what the social determinants of health, or the enhanced social determinants of health use case, is all about. We can go to the next slide. All right, and we use the term data lakes a lot at MiHIN. For the messages that are flowing through MiHIN, we do also store that data, but again, it is still specific per use case, how long we store that data and how that data can be used. But the idea of a data lake is it's very similar to a database, but it can have triggers and things, and it can be more of an interactive world than a traditional database may be. So there can be a lot of different things monitoring and listening to the same data lake.
So as we start to kind of look towards the future, it's always important to kind of take a look back at how things evolved and what has happened along that journey. So social determinants of health really became that new buzzword in healthcare back in 2017 and 2018. And it represented a recognition that how people live, work, play, sleep, and their ability to access those basic needs within life really impact their health far more than medical care or traditional health care really can. And that is a very poignant recognition because of the amount of money that is being spent on healthcare, medical care within this country, and the willingness and want to be able to continuous quality improve that process, when in fact we could, it might better serve ourselves by focusing a little differently. So in 2018, Michigan really began that SIM work, and it started the conversations, it started movement, it started regions organizing around this work. And at the same time that was going on nationally, there is this recognition that there's no real data standards that exist that allow social determinant of health data to flow and be aggregated together. So that's a bit of a problem, because we've done this before. We did this with electronic medical records way back in the day, where everybody could have an electronic medical record, but that information was siloed within that specific medical record and could not be aggregated for the greater world back in when the Institute of Medicine kind of put their drive into gear, that's when standards really started to be developed, and we saw a greater improvement in that data. And ultimately led us to where we are today with that recognition that social determinants of health really impact that, that quality far more than we initially thought. So when we talk about the Gravity Project is really that group that is harnessing and trying to create those standards. And that work began in 2018. An important kind of factor in the approach that MiHIN has really taken is that we want to remain vendor agnostic, and we want to focus on that ability of the data to flow regardless of what system you're using. In early 2019, MiHIN created that first generation of the SDOH use case, and that was really meant to align with the state innovation model, because that was the work that was going on in organizing at the time to better understand the needs within the community and better understand what was happening. So it was a first pass at it. Through the feedback of stakeholders at the time, though, it became clear that trying to organize around a single screening tool was really very, very difficult. There are too many variations. There's too many organizations that have engaged in this work already. There's too many populations to represent, all which require that flexibility. So identifying based on need was really a primary feedback of the stakeholders at the time. In late 2020, there was work that went on to release an updated use case to attempt to move past the idea of just screening and into what's happening with these people after they screen. Where are they going? Bigger challenges were really brought out, though, in the sense that community-based organizations who do this work largely in the community already were largely left out of the conversation entirely. So being able to bring those stakeholders in and help to understand it from their perspective, both in terms of data flow and models that are ultimately created. So being able to bring in that wider group of stakeholders. And as fate would have it, it threw us a really awful twist with COVID-19, which really highlighted all of the problems and highlighted the health equity gaps even further. So it placed a microscope over top of this whole system and said, these are glaring problems. And that can be very good. That can lead us to a sense of urgency. It can both complicate factors, and it can also expedite factors. So we're in that kind of strange territory right now where there's a lot of movement going forward. The steps being taken by MiHIN really reflects that focus to ensure that data exchangeability and support for regional solutions as we move forward. A refocused energy with that idea that there is a program and refocused energy. Next slide. So we threw this in. It's always good to kind of have a visual depiction of kind of what we're talking about in terms of data gathering. And this is that Gravity Projects conceptual framework. I like this, and I just like this because it really reflects a lot of what has been talked about with a very medical centric focus. But if we stop thinking about this in terms of wordsmithing it and really start thinking about how data is collected at each one of these points and what the important factors are. So screening data is really just that. It's screening data. It's not meant to be kind of a solid action item from that point. That really takes care teams, whether that's social care teams or clinical care teams, to be able to interpret and understand what the real issue is before you arrive at an actionable item. In medicine, we call that a diagnosis. Within the social world, we may call that something slightly different, but it's an actionable item that says there is a need here, and this is how we're going to move forward towards resolution, towards getting that person assistance within the community, and understanding all the way along and being able to aggregate data all the way along. So that's the framework that the Gravity Project is using to be able to define what data needs to be gathered. And they are doing it from a very cross-disciplinary focus. Any questions about the Gravity Project? So when we talk about it, when we say MiHIN says we're aligning with the Gravity Project, we're aligning with the standards that are being set out to ensure that it's not a Michigan-centric focus, that it is data that can be exchanged regardless of where that individual is. If there's no questions, I'll move on. So there's no doubt that there is a lot of work that is happening within Michigan at this point in time. There are lots of regional efforts. Platforms come into this space and really kind of say, hey, I can solve the whole thing. But make no mistake, platforms remain siloed information. And the goal of MiHIN and the role of MiHIN is to ensure that that data does not remain within the silo, but can be exchanged. As standards are developed, it can be exchanged between whatever platform is being held. And a platform may seem like a really, really great idea, and they can be incredibly helpful. What happens at times, though, is community-based organizations really get trapped in between platforms that come into different geographic areas. So if you have a AAA or you have a different community-based organization, they may be approached by 3 different platforms to be part of that silo of information. And then you are left with, which one do I go with? Factor in MyBridges, and MyBridges mandates certain organizations to participate. So it complicates this picture even further. The goal and the role of MiHIN is to ensure that that data model allows us to stay vendor neutral and exchange the data for what it is, freeing that data for the better purpose. And that better purpose really has to remain the focus of the patient and the care team. We could have the most technically accurate and well-developed technical solution, but if it interferes and complicates further the work of care teams in social and healthcare, then we have not created something that is going to work long-term. It's going to add to that administrative burden that is going to continue to crush those efforts. So keeping the patient and the care team at the focus of the work in social determinants of health is a guiding light for this program. Next slide. So back in the fall of 2020, there were social determinant of health work groups and focus groups that really helped to inform development, better align with community-based organizations in this work. However, it was really clear from that there needs to be a wider reach out into those community-based organizations. And it also helped to clarify what those barriers are within the state of Michigan and ultimately nationally as well that shape MiHIN's role as we go forward. Adding to that is the State Health HIT Commission that released an environmental scan in May of 2021 that informed and reinforced a lot of what was heard through those workshops. And from that, we came to recommendations that really informed the work going forward. So next slide. So the recommendations that really were heard loud and clear is that there had to be a use of a phased approach for social determinant of health use cases, design and implementation. And not all organizations are going to come into this work having the same capacity, having the same understanding. Not all regions are moving forward at the same pace. So being able to meet organizations where they are with what data can be submitted and understanding that and allowing that level of flexibility was a key recognition in how we approach this, and it helps to start that data actually moving along. The second recommendation really came out of that idea of a single screening tool versus the flexibility of being able to screen populations and using tools that are already embedded. So kind of moving away from the state innovation model and understanding what stakeholders and end users really need to be able to participate. So allowing need identification and mapping that backwards towards questions. The other recommendation was normalize priority social determinant of health domains. There are 13 domains that are considered priority within the state. and you will see those reflected in that file specification. There was also broad support for understanding and being able to bring people together into a statewide social health consortium that really kind of draws on the expertise of people on the ground understanding this work far more. So being able to convene that statewide social health consortium and continued stakeholder engagement. And that's something that with the onset of COVID, with a lot of things that really kind of have been in flux because of the pandemic, coming back to and really reinforcing that stakeholder engagement is also going to be a key concept in the program going forward. Next slide. So this is where I'm going to turn it back to Mike, who is, again, more technical than I am. So Mike.
Thanks. I think there's a, you can click one more time. I think there's this, yeah, the right side. So in 2021, we were really, the theme of the whole thing was trying to operationalize what we inherited from the State Innovation Model project. And as part of that, we looked at the State of Innovation Model work that had been done, and there were 15 questions that all the SIM participants had been asking, and all the information that was being exchanged was really focused on those 15. What we tried to do was open things up to be less constrictive from a focus on those 15 specific questions, and instead trying to look at gravity recognized
Uh-oh, that's never good. I think we may have lost Mike to some technical difficulties. Joanne, can you still hear me?
I can still hear you, but poor Mike went, I don't know where he went. He has like a.
Poor Mike went bye-bye.
Bye.
All right, so I'm going to try to take over, and hopefully Mike will join us again very, very soon. So some of the things that are new is really that idea that questions get mapped back to the domains of need. So you can utilize and specify what questions are being asked, which provides that level of context. Mike, did you join us again? Nope, still no Mike. I keep hoping. So you can submit any social determinant of health screening question from any tool that maps back to the Gravity project domain. Again, providing that level of flexibility and removing one of those barriers that really was key feedback to the during workshops and through stakeholder engagement. MiHIN will continue to store that screening data and make it available through MyGateway's patient viewer and TOC viewer modules. There is some updated data reporting that is being built and to support those end user needs. We're going to take a look at that in just a minute. But really, as Mike, I think, said earlier, it was really about taking what was started through the state innovation model and trying to move past it and forward so that we could really get broader stakeholder engagement and really start to allow data to flow for the benefit, again, of the patient, of the care teams that are involved. The changes also include some population health. Hi, Mike.
Hi.
You're back.
Sorry about that. I was talking away, and then it said I was having network problems.
No worries. They got the really awful version of this.
The real takeaway, if I could put it into a nutshell, is that if you are already participating in social determinants of health, the old specification and what you're doing is not going away. But we are releasing a new specification that allows people who are using any social determinants of health screening tools that can map to a gravity recognized domain to participate in the screening use case. We did also build some reports and analytics to be able to look at The data.
Oh no. Lisa, go. Kyle, keep it moving. We've got more.
All right. So this is something fairly new, and we are looking at this to be deployed fully through by the end of October. And these are analytics that are available to anyone who submits that data. And it really allows us to break down information from screening, from referral, if you're submitting for referral, that type of thing. It allows you to break it down in multiple different ways. It is the beginning and the base of a tool that allows broader thinking about what questions need to be answered. Can I see what this looks like? And it allows individual regions to be able to get in there, utilize that tool without having to build it themselves and without having to say, here's a flat file of all the information. Now you figure out how to go out and utilize that data. Some organizations are going to be much more attuned and capable of being able to do that, and other organizations are not. There's also a really great feature that allows that data to be overlapped with geography, which is very important when we start to consider solutions going forward and start to consider where these needs really exist.
Lisa,
graphical representation, so on and so forth.
Amy Robertson wants to know when updated social determinant of health specs will be available. Do we have that information?
Today. You will receive a copy of that, and it's really just kind of going through and being able to allow you to map that back, as well as add in a couple of additional elements to that data capture surrounding health equity. If we want to move on. Again, this was meant to be Mike. This is really just kind of reinforcing that there are increased, for patients, we want those increased opportunities to screen and to be able to better identify and better be able to kind of connect those individuals with care within the community. Understanding how that happens and being able to respond to stakeholders to remove those barriers was the primary result of this year's use case. The other thing that we wanted to reinforce is that there is going to be, this work is ongoing at the gravity level. This work is constantly evolving, both regionally and at a state level and nationally. So there will be a yearly update that helps us to remain current, to stay aligned with national level efforts, as well as improvements that we want to see happen within the state. So that is an expectation that there will be an annual update, and that is an important concept that we want to drive home. We are going to be turning our attention to those community-based organizations, trying to get greater engagement with them and understand their role within this overall care model. Any other questions about that before we move on? All right, next slide. As we've talked about, late fall, we're looking to host a community-based organization summit to understand things. Feedback is critical. It is really important to understand that this work is not going to be a top-down approach. This cannot be a top-down approach. This has to be a bottom-up building of something that works for the patient, for the care team. We have to preserve that. So if you're a community-based organization, or you know of a community-based organization that really should be involved, we have our own kind of like understanding. We are going to be reaching out to try to get that engagement. If you have any interest or more curious about it, please feel free to reach out to me. We should have a date for that relatively soon. Next slide. So in terms of the next steps to onboard for that social determinant of use case, when you leave here today, you are going to be receiving an update that includes the actual file specification. If you have questions about that specific file specification, you can reach out to Mike Taylor specifically about that. He can answer some of those basic questions, just clarifying questions. If your organization is ready to onboard to that social determinant of health use case, please contact your account manager, or if you haven't worked with MiHIN before and want to start to learn more about that, please email help@mihin.org. If you're curious about what's going on from a broader scale, my door is always open if I had a door that you could walk through. If not, please feel free to reach out to me directly.
Thanks, team. What I always thought was really interesting when I found out some data from our state innovation model was that even though people had needs, they didn't want help for those needs. And I think that as we move into our next presentation, I think it's really important to recognize, you know, who's asking people if they need help. And do those people trust that the people asking will be able to deliver the help? So not only screening, you know, not only asking the right questions, but making sure that the right person is asking the right questions. Again, we are only human. So with that said, we're going to have Sammy Madsen Olson talk to us about a care coordinator's onboarding process. So, you know, who might people with most needs trust to help them? Well, perhaps it would be a care coordinator. Sammy, please tell us what this is about.
Happy to. Hi, everybody. Like Joanne said, I'm Sammy Madsen Olson, and I'm a project manager with MiHIN. Kyle, can you go to the next slide, please? All right, so I'm gonna be moving through this content pretty quick today, but I am gonna get you guys the important aspects. We're here to talk about what is CCC, which stands for Coordinating the Care Coordinators. We're gonna talk about who can participate, the value that service is gonna bring to your organization, and then how you can take next steps if you're interested in participating. So next slide, please. Thank you. All right, so some of you might remember that MiHIN has been working on care coordination for a long time. Back in 2017, 2018, we convened a stakeholder workshop that worked together to create a multi-stakeholder definition of coordination of care. You can see it here. I'm not going to read it off to you, but we basically define what sort of activities constitute coordination of care. And got a lot of consensus around that, and we're very happy with it. Next slide, please. So most organizations, or many organizations, have care coordinators on their staff. Maybe you don't call them care coordinators, but they do fit into that definition on the previous slide. And here, there's a lot of value that you can get by bringing care coordinators more into the health IT world and getting them data. First of all, it supports the ability for those resources, those care coordinators who couldn't previously participate in MiHIN services, to register in our health directory and declare their own active care relationships with patients and the people that they serve. Secondly, some care coordinators have something called an NPI. I think we're all probably pretty familiar with that. It's a national identifier for providers. However, although they might be in our health directory or might have been previously, they could have been misinterpreted as a clinical provider or just sort of miscategorized. And the benefit of the new care coordination, the benefit of adding your care coordinators to APD now is that we're going to be able to identify them as care coordinators. And more than that, we're going to be able to address their specific area that they work in and the services that they provide to patients. Next slide, please. So what can you do? Like I was saying, the health directory will now show individuals as care coordinators if they've been registered in that way. Even those who do not have an NPI, which used to be a requirement for folks to enroll in the health directory and declare their active care relationship. So we're very excited about that. Basically, this opens up MiHIN services to a whole group of people who are providing very important care to patients and the people that they serve, and giving them the tools they need to do their job better using health IT. Next slide, please. So who counts as a care coordinator in our definition? So there's a bunch of information here, but essentially their role is identified as being a care manager, case manager, patient navigator, health coach, those sorts of roles. Also, if their functions sort of fall into any of these categories, so completing needs assessments, basically looking at or addressing the patient's short-term, long-term needs, helping that patient to manage their healthcare transitions, and then also anyone who's helping out in the public health emergency coordination role. Some people might not be within those criteria that I just described, but they still provide some element of care coordination to their patients. If that is the case with your care coordinators or whatever their title is, refer to that multi-stakeholder definition on a previous slide. If they fit into those categories, they should absolutely be counted as a care coordinator in our system. And it's easy to go ahead and get those folks enrolled. So I'll talk about that in just a moment. Next slide, please. All right, how to participate. We can go to the next slide. Technical onboarding. This is actually one of the easiest onboardings that I've seen at MiHIN, and a lot of them are actually pretty simple. Just 3 steps here, to be honest. The first one, super easy. Let us know that you're interested in enrolling your care coordinators in the system. You can either reach out to help@mihin.org or contact your account executive. There's many different ways to get into that data flow.
Also, guys, I'm going to be
Secondly-
following up with you, directly. So I'm, like I said, I'm kind of not letting you go. So you can tell me and I will pass on the information. You can always use me to connect. Sorry, Sammy, I just wanted to.
No, that's fine. And Julie, I'm going to answer your question in a second. I saw that in the chat. Next step, we send you a form, a batch enrollment form, where you give us some information about those care coordinators and then send it back to us. And we go ahead and take that batch enrollment form, upload it into MiHIN's health directory, and then you'll receive what we call care coordinator IDs, which can be used to include your care coordinators in your ACRES files and allow them to declare active care relationships. And then the last step is just start using it. Once your care coordinators are onboarded, they can participate in many of the MiHIN use cases and start leveraging that data. Next slide, please. Legal onboarding, there is no specific use case exhibit, no additional legal that you need to sign to participate in this. Most folks on this call are already going to be fully executed on these legal agreements, which include the health directory, the active care relationship service, and ADTs. So very, very low bar, low barrier to begin participating here. Next slide, please. All right, so the batch enrollment form, I won't go over this in detail since we're running low on time, but essentially what you do is you send us a list of your care coordinators with some of their information. You can see the fields here, and go ahead and skip 2 slides, Kyle. That's perfect. And so you can see there with a red circle, you will get back that batch enrollment form with some additional information, specifically the care coordinator IDs. So that is what's going to replace the NPI in that ACRES file. So you just put it in the same place, and then you can declare those active care relationships for your care coordinator. Next slide. We'll go ahead and skip this one for time. It's more of the same. All right. So yeah, essentially, this is a way for you to get your care coordinators more information, allow them to act more autonomously, and just be more involved in the healthcare landscape that we can provide. So I will go ahead and pass it back to Joanne, or take any questions if we have time.
There was one more question in the chat, which I would like to know the answer to. Thanks.
Sure. So from Amy Robertson, with CCs being included, will notifications be sent to both the provider and the care coordinator, or will we have the ability to choose? So I believe that it would go to anyone who has declared that active care relationship. So if the provider and the care coordinator have declared that, then it would go to both. Will updates just require a new batch form to get the IDs? Yes. So it should be really simple. If you have new care coordinators that you want to enroll, you can just resubmit that batch form and we'll get that going.
Thank you, Sammy. So
thank you.
Again, if we are talking about what will make people healthy and well and how they get the services that they need, sometimes care coordinators are the key. And if a system designed to create, health and health equity can't see who's helping the clients, so if the care coordinators are invisible, we're missing so much, especially about active care relationships. Okay, now we are moving on to Mary Krantz, who's got all this stuff to download with us. Thank you, Mary. What do you have to tell us?
Well, thank you, Joanne, and thank you to everyone for the privilege and opportunity to present today on some of our HIE industry trends and a little bit of education on this fast healthcare interoperability resource, or FHIR. Is my audio okay? Just doing a quick check to make sure. Very good. If you can move to the next slide, please. So Interoperability Institute, mission of healthcare interoperability, and really the innovation pipeline for MiHIN, providing both the development team and looking at market trends, and really would love some interactive feedback from this session on our stakeholders around the industry trends that you've been seeing and where our assessments at the Interoperability Institute are coming in. So the objectives for today: understand where we're at with our health data exchange, take a very brief look at some of the emerging rules coming from the federal government around what all of us need to be compliant with for new aspects of interoperability, look at some of the gaps that exist in the current standards that are actively being developed, and then finally look at how this new FHIR standard impacts the future of interoperability and the services that MiHIN provides. Next slide, please. So we're all, make a basic assumption that we're all very aware of the issues that exist in healthcare today, from access to healthcare data that is inhibited. I was really struck by Lisa and Michael's presentation, part of a national conversation around that exchange between health and human services, and the notion that in the human services space, is a homeless shelter going to be required to provide their client list to a provider, to a care provider, and vice versa? Would a care provider be mandated to provide that information to a homeless shelter that an individual was COVID positive, for example, or had been vaccinated or not vaccinated, for example? So lots of legal, policy, technology dialogue happening at a national sent at a national level around all of the issues that we see in healthcare today. But for me, it's really still striking all these years later, after the National Academies of Science came out with a report on To Err is Human, we still see about 80% of our serious medical errors are because of miscommunication in our information systems. Seeing 250,000 deaths a year in hospitals due to medical errors, and also as part of our finger on the pulse of industry innovation, was really struck by an assessment that was done by Peraton, and that it takes 17 years for a best practice in the health sector to move into clinical workflows. So in this trillion-dollar cottage industry of healthcare, where the majority of our Medicare expenditure is on chronic diseases, cancer, diabetes, it still takes 17 years for a best practice to move into our clinical workflows. And so just wanted to frame up this discussion around the importance of standards, the importance of accelerating the velocity of our innovation pipeline. Can we track that back to, it only takes a decade, or it only takes 5 years to take a new precision medicine methodology and to be able to have it positively impact all of the chronic diseases that are being costed today. Next slide, please. So I wanted to take a little bit of a deep dive today on the Health Level 7 standard. Not sure how familiar the audience is. I'm sure everyone who works in healthcare has heard of HL7. It is an American National Standards Institute accredited standards development organization. And what that means is that the HL7 standards body, of which MiHIN is a member, it's a consensus-based model where the industry comes together and has a process model defined by ANSI that defines industry standards for the health sector. So I think we're all very familiar with some of the current HL7 standards, what's referred to as V2 or version 2. This is our traditional electronic data exchange standards. We're using those today for the used for immunization records. We also have in the HL7 standards the clinical document architecture, or CDA, and now the CCDA, which is a consolidated for all of those clinical notes. So HL7 is a very comprehensive package, but a lot of the HL7 focus to date has been around defining the standards for electronic health records. And with the advent of the high-tech regulation from the federal government, a lot of resources went into the HL7 standards to define those EHR standards. So as we look at this current version 2, fully recognize that there's a lot of limitations to these standards. One, these electronic data streams, they're not really human readable. The HL7 standard is delineated with a backslash, and so you don't know the exact data element and don't have that long string of hundreds of data elements committed to memory, it's not human readable. There's no central location, and there's lots of challenges around doing federated systems with this model. It doesn't really address a single data type. So some of the issues beyond a data type that just might be an alpha or numeric, but as we know in healthcare, we have very robust terminology services such as SNOMED, ICD-9, or 10, excuse me, et cetera. And so we have lots of complexity for computer systems when it comes to defining and standardizing on data types. And HL7 version 2 is a little weak when it comes to data types. And sometimes these message streams, it's sort of a one-stop shop it gives you too much information, thus creating potential security and privacy risks. Next slide, please. So in addition to this sort of juxtaposition, there's a number of gaps in interoperability that have been defined by the Office of the National Coordinator. And just to briefly recap, as these standards are being developed in the industry, we're recognizing the need for a trust exchange framework and to come together around common agreements for how we exchange data and information between different entities across the sector. Establishing these qualified health information networks, we have the US QHIN activity within the MiHIN constellation. Very, very exciting to see that you can pre-qualify to know that this entity can reliably exchange data and have a common data dictionary of the metadata and the definition across a health information network. And the HIEs are central to that process. Establishing the recognized coordinating entities, and I won't read through all the details of this list, but ONC is, across the industry, is looking at these gaps in interoperability and is asking for healthcare entities to voluntarily look at subscribing to agreements as an industry that is under this TEFCA, Trusted Exchange Framework and Common Agreement umbrella. Next slide, please. So breaking that down a little bit further, some of the value proposition that the Office of the National Coordinator in Health Information Technology is bringing is looking at different stakeholders within health sector, be they patients, providers, or health information exchanges, vendors that work in health IT, and being able to define programs, provide resources to be able to address a variety of gaps in interoperability. And I won't read through every piece on this list. Certainly the presentation will be available, and the ONC website has a lot of detail on each of these. Next slide, please. So in addition to ONC, we also have the Centers for Medicare and Medicaid, CMS, equivalent, looking at where there are gaps in interoperability and really a focus on making our systems more efficient, more cost-effective through standardization of something that we call APIs, or Application Program Interfaces. The interesting thing with these APIs is a whole number of entities have defined APIs, Epic, Cerner, Allscripts, the payer organizations, etc. But from personal experience, when you go to those vendors, the Interoperability Institute has a sandbox or a innovation test environment where we can look at different aspects of interoperability. And when you ask entities, would you expose your API into this sandbox environment? It's really, really challenging for private sector vendors to actually open up their APIs and make those available for true interoperability testing. We're seeing this a lot with the HL7 Connect-a-thon activities, where there's lots and lots of participants coming to the table. But one of the things the Interoperability Institute team has been working with is the leaders of the standards organizations and some of our key MiHIN stakeholders to be able to open up those APIs and explore many of the nuanced aspects of interoperability, specifically around the use cases that we saw with SDOH. Payer-to-payer data exchange is certainly a focus with the upcoming federal mandate, et cetera. And then the same for providers. All of the issues around information blocking, I just mentioned with the homeless shelters is just one example. So in the solution space, CMS has defined that the FHIR standard, this Fast Healthcare Interoperability Resource, or FHIR, is mandated in the legislation. And so this FHIR standard is based on web services, RESTful APIs, technology that's been around for more than a decade, is used in a lot of other sectors, but is now being applied in really powerful ways to the health sector. And I see we're running up on time, so we're going to quickly go through the next slides. Next slide, please. So the FHIR standard is based on resources. Next slide, please. That provide different building blocks. If you can just matriculate to the slide that actually has the visual. So these resources are organized into modules, and there's basically 5 levels with different modules for all the different key aspects of healthcare interoperability. First, there's a foundational level, but it gets into the clinical, the diagnostic, the devices, the financial, et cetera. So as an industry working through this ANSI consensus process, the HL7 standard has defined the FHIR standard is an amazing way that we can address all of these issues in healthcare interoperability. Next slide. I think we're getting close to the end here. So FHIR solves this. Next slide. Next slide. I wanted to very briefly mention that within HL7, they have defined these activities called Accelerator Projects as they imply to accelerate the implementation of the FHIR standards. So if you hear Da Vinci or Codex or Vulcan, they're just projects within HL7 to accelerate moving this standard, the FHIR standard, forward for the industry. And I think with that, we are at conclusion with 2 minutes to spare. So in summary, there's a number of federal rules that MiHIN is paying attention to. Undoubtedly, all MiHIN stakeholders are paying attention to as we look at interoperability and this important FHIR standard, the ONC Cures Act, TEFCA, the CMS Interoperability Patient Access Final Rule. I believe from what I've seen in the industry is that the industry is going to pivot on a dime from our traditional version 2 HL7 standard for electronic data interchange to these FHIR standards. I believe that will happen within the next 3 to 5 years, but because of the regulation coming from the federal government, that may actually occur sooner. And with that, I'll turn it back to you, Joanne. Thank you.
Okay. I mean, really, can you think of, I mean, we really covered so much. Mary, Lisa, Mike Taylor, Sammy, thank you. And thank you everybody for being here. These are monthly webinars. We want to make them as good for you as possible. So I will follow up and ask you what you guys want to learn, what you want to talk about, and how we can better serve you. Thank you for being here. Have a wonderful, wonderful month. We'll see you next month.